Hospital, Kota Damansara. His main clinical focus covers general urology, men and women's sexual health, hormone replacement therapy, and male infertility. He has been effectively and consistently incorporating BHRT in his practice. Qualified as a doctor since 1997 and have extensively been trained in multiple centers across Asia and Europe. His commitment to advancing his skills led him to fellowship in minimally invasive laparoscopic surgery, including training in Austria and India. As a senior lecturer at the University of Malaya, Dr. Muhilan has not only treated countless patients with compassion and expertise, but has also trained and mentored the next generation of surgeons. Over the years, he has contributed significantly to urological research, particularly in prostate health and urinary disorders, earning him the Malaysian Urological Association Research Award. He had done extensive research on prostate cancer and overactive bladders and published in respected journals. He has also represented Malaysia at numerous international medical conferences. Now, please join me in welcoming a surgeon, a researcher, and an educator who continues to raise the standard of urological care in Malaysia, Dr. Muhilan Parameswaran.
So, TRT is easy. If I sell it to you now, it sounds like magic medicine that cures everything as you get older, right? But when you give it out, you need the proof, you need the evidence. And what we're going to do today is very simple. I'm going to tell you how it works. I'm going to tell you how to do a simple, straightforward diagnosis. It's not rocket science. But more importantly is, if you see all the slides, and this is mostly for you all to read, I've tried to simplify about 5 randomized control trials that you can use as level 1 evidence in case anybody asks you any questions. Where do you have the evidence? Why do you think it works? What's the side effects? It's all here. Okay? But the slides are very busy. So it's mainly for you to read on your own or look it up or use it as a reference if anyone asks you. Okay. The simplified version of those trials, I'll go through with you. Okay. I prefer interaction, right? So every 2 or 3 slides, ask me what you want. Okay, you don't have to wait till the end. That means if I finish how it works, you want to ask me a question, ask. I'm fine. I'm good with it. All right? And that makes it such that everyone, because we all have the same doubts, we all have the same queries. So if you all have something, ask. It doesn't matter whether it's basic, not basic, whatever. Just ask. Okay, don't be shy. All right. So the basics. Okay. Testosterone is a hydrophobic molecule. Now, why is this important? What it means is, okay, everyone is familiar with potassium, sodium chloride, right? That can travel through your plasma on its own. You don't need anything to carry plasma or sodium, right? Sodium can travel on its own. Cholesterol synthesized hormone, which testosterone comes from cholesterol. And for life of me, it's a multi-step pathway, which, long story like, don't even remember it, tapenting one. Okay? So cholesterol to testosterone. But for testosterone to travel to its target cell, which is everywhere in your body, your brain, your muscle fibers, everywhere, it needs to be carried with a protein. So 2 proteins, SHBG, albumin, right? Easy. When it's bound to SHBG, it is very solidly bound. It's like stuck. Why is it important? SHBG levels go up in diabetes. They go up in metabolic levels. So if you don't know that, you will measure testosterone and think testosterone levels are huge, when in fact most of it you can't use. Second protein, albumin. Now albumin, it doesn't stick so sticky, put it that way. So it can be released from albumin to enter the cells. All right. So transport through the system, SHBG and albumin, and when you measure the levels, you are measuring SHBG level, SHBG with testosterone, albumin with testosterone, and a little bit of free testosterone, which is the active component, usually about 2%. So ballpark, if you can see a number for a healthy male, 2%. Now, Up to here, clear, right? Simple. I've simplified it as much as I can, right? Cholesterol produce, transport SHBG, albumin, which means anything that blows up albumin levels, anything that pushes SHBG levels are going to affect testosterone levels. That's your diabetic patients, okay? Or metabolic syndrome patients. Now, where am I next? Okay, same slide. So SHBG 66%. That means 66% of what you measure, your body cannot use. All right? Albumin 33% can use, and the free 1 to 3% you can use. Now, when it reaches a cell, it's hydrophobic. That means it can directly enter the cell. It sticks to the membrane, it goes in directly. Then we go to an androgen receptor, which is outside the DNA, the nucleus outside. Why is this important? Nobody knows what is normal androgen receptor level. So that means I can have a free testosterone of, say, 10. My colleague over there can have a free testosterone level of 10. He can be healthy, I can be sickly. Because why? We don't know how much androgen receptor there is in a cell. So using biochemical values, pure biochemical values, you're asking for trouble. Because it doesn't make sense. You see people at the same level, one feels like shit, one feels like Superman. Because we don't know enough about androgen receptor. There's a lot of stuff we don't know. I'll try to be honest with you. I'll tell you what I don't know. Okay? If I know something, I'll tell you. Okay. It enters, it binds to androgen receptors. It then splits, it divides. Dimerization means it just forms two. Enters the DNA, and you get gene transcription. Gene transcription, what does it mean? It's the first step in gene expression. That means the genes start producing proteins that does all the magic stuff. Increase your muscle mass, reduce your fat mass, increase metabolism of sugar, make you feel better because your CNS feels better. That's gene expression. Okay. This is the minimum you need to know about testosterone synthesis, how it gets to the cell, and how it does its work. So testosterone is an endocrine hormone. Okay. That means what? It circulates in the body and goes far away. It circulates the entire body. How many of you remember medical school, right? Paracrine next to the organ, endocrine everywhere. It's an endocrine organ. It's going to affect everything in your body. Right? So remember this. You take testosterone, everything in you changes. Top to bottom. Hair, skin, eyes, everything. It's an endocrine hormone. Okay. Up to here, how am I doing? You guys got a clear picture so far? Am I so good at not getting any questions? Okay, really? No questions? Okay. So remember this, right? Anything that affects the receptors, sorry, just realized not clear. Anything that affects SHBG, anything that affects albumin levels, and of course testosterone production is going to throw the numbers off. Okay? Right. How do you control it? We all have a control system. Textbook says really easy, right? GnRH, that's from your hypothalamus, goes to the pituitary gland. Pituitary gland produces LH and FSH, but let's focus on LH. LH sends a signal to the testis. Testis produce testosterone. 99% testis, right? Ladies produce on the ovaries and adrenals. Now, the feedback loop is very simple. If your testosterone levels are high enough, the feedback goes back to the brain. Pituitary shuts down LH levels, testosterone levels will fall. How does this work for you in real life? At its base, before you start testosterone therapy for anybody, please do a blood test. 2 reasons. 1, you should at least try to find out why this patient has low testosterone. You have a diagnosis. 2, if anybody asks you in a court of law, why did you give this patient testosterone? You at least have done your homework. You have documented clinical symptoms, which I'll come to, and you have documented labs. How many of you are aware of Singapore case? Anyone know? No. Okay. Singapore, private practitioner got hauled up in court for giving out hormones with very little documentation. That means no lab values, no documentation of symptoms. Basically, the expert witnesses could not tell you why patients were given hormones. He lost the case. He's on suspension from the Singapore Medical Council, and he had to pay a huge fine. So document at least this much. Okay. So I'll give you some simple tests. Okay, forget fertility patients, forget the gross patients. Your average patient is going to be this. For now, we'll ignore women. I'm sorry, I'm just ignoring women for now. We'll come back to you later. For the guys, you're going to see this older guy, 50s, 60s, or younger guys, and you're going to see low testosterone, LH sort of borderline, FSH borderline, right? But testosterone will be low. So testosterone low, LH borderline, by right, LH should be high to produce more testosterone. What can produce this feedback loop? There are other things that affect this feedback loop, including hypercholesteremia, not hypercholesteremia, hypercortisol levels, which means stress. Stressed out individuals, people with poor sleep, the feedback loop doesn't work so well. So this is your number one type of patient. You'll document low testosterone and the LH will not be super high. This is what in real life you're going to see. Bad luck, you then get the other extreme. Patients with testicular failure. Testicular failure, super low testosterone level, almost unmeasurable. LH, FSH sky high, because the brain keeps telling the testosterone to produce, it tells the testes to produce testosterone, nothing happening, LH, FSH goes up. Testicular failure. Testicular failure, straightforward, give testosterone, there's nothing else for you to do. Fertility is a different issue, which we are not discussing today, but anyone who's not in it for fertility, testosterone is the only treatment. Now, you have another patient, okay? Low LH, low FSH, and low testosterone. I mean, all three is low. So that's something disrupting the feedback loop. No, for whatever reason, the pituitary is not working. Now, why is this important? How many of you have heard of pituitary adenomas? Got? Okay, so you have tumors in the pituitary gland. Or you can have an infarct of the pituitary gland. So if you have this, low LH, low FSH, low testosterone, the problem is the brain, the pituitary gland. Please do an MRI. Do a prolactin level, do an MRI. Make sure you're not missing a pituitary tumor, because that's going to come back and bite you on the ass. Okay. So I've given you three scenarios. These are your three commonest things you're going to see. Number one is that obese patient, low testosterone, LH, FSH, so is because he's got high estrogen levels, he doesn't sleep well, and his cortisol level is sky high. If you're going to measure cortisol, you have to do a series. That's a different topic. You have people with testicular failure, I'm just simplifying it, and you have people with pituitary failure. Three common scenarios. Okay? All right. Up to here, you guys good or not? Okay. Am I moving too fast? Seriously? Okay. I'm good. Okay. All right. Okay. So as I said, oh yeah, okay. So the one where I said you got low borderline LH, borderline FSH, and low T, right? Trace minerals low, I'm starting to see now in the last 5 years. It's something I never used to see. The last 5 years, I'm starting to see low loss of trace minerals that includes vitamin D levels, zinc, selenium, and magnesium, partly because dietary patterns in Malaysia have changed in the last 10 years. Our diet now is very, very highly processed food. I'm not going to have pizzas, mihun, kway teow, buns, breads as a staple. So the number of families who have regular 3 meals a day, rice, vegetables, meat, is actually not as high as you think. People are eating fast food, people are eating processed food. Problem with processed food, there are many problems with it. Trace minerals are very, very low. Okay? And you will end up, if you start measuring and you start correcting, you need zinc, selenium, vitamin D for production of testosterone. And if you're not there, you're not going to get it. So a simple thing is, I think our labs all of you all have your own lab services, right? Okay. How many of you all have actually checked zinc, selenium, magnesium? One person also tada. None of you all check trace minerals. Okay, it's not that expensive. Vitamin D at least. Okay, how many of you all check vitamin D? Okay, so vitamin D good. Try to chuck these three in. Because even if you start giving testosterone,